Hello everyone, welcome to this video from Onconews channel. My name is Dr. Denis Jardim. I'm a clinical oncologist from São Paulo, Sírio-Libanês Hospital. And today is my great pleasure to have with me here Dr. Thomas Powles. He's a professor in GU oncology and director at the Barts Cancer Center in UK, London, UK. And it's a very important leader in the field of urothelial and GU cancers. And today we're gonna discuss about the plenary session presentation from Javelin 100. So first of all, I would like to welcome Dr. Tom, and I also would like to congratulate you from this great achievement. It's something really important in the field. I believe is the first plenary session presentation at ASCO of an urothelial cancer. And Dr. Powles started researching about immune checkpoint inhibitors since a long time. I remember the first paper in Nature about the NPDL drugs. And now we have here with a lot of achievements. Welcome, Paul.
Thank you, Dennis. And it's really sweet of you to give me that introduction. You know, I know that a lot of people took part in this study and all of the other studies too. And I know that includes a number of sites in Brazil and your fantastic country. So I think it was a global effort. Actually, the trial involved over 200 sites, and we recruited 700 patients into the study. But it is really important to realize that it was a global achievement. The study wasn't the easiest study to recruit into because there were other trials going on at the time that started before. And so it's a very sweet introduction, Dennis. You and I know each other well. It's probably why it was so sweet, but it really was a global effort.
No, it's really a pleasure, Tom. So this is a practice-changing study. So I have some questions with you. We're gonna discuss some important points with our folks here in Brazil. So to start, please give us an overview of the results, from the main results of Javelin 100, especially including the number of patients that got immune checkpoint inhibitor after progression, because this is important to understand the value of maintenance for those patients.
Yeah, so I think that's a good question. So just to summarize really quickly, the principle of immune checkpoint inhibitors as it currently stands is that frontline therapy for metastatic disease is based around platinum chemotherapy, either GemCis or GemCarbo. Immune checkpoint inhibitors have not yet really established themselves in that space in randomized trials. The immune checkpoint inhibitors are, however, established in platinum refractory disease second line. The problem with that is that many patients don't get to the second line space. And those that do, many have aggressive disease and don't do well with immune checkpoint inhibitors. And so therefore, the scientific rationale is that if you give maintenance therapy directly after chemotherapy, you can get initial control of disease. And that initial control with chemotherapy then buys time for the maintenance immune therapy to achieve a survival benefit. And so in the avelumab trial, avelumab's a PD-L1 inhibitor. In the maintenance avelumab study, you had 4 to 6 cycles of platinum-based chemotherapy, and then those patients that had stable disease or responded were then randomized in a 1-to-1 manner with 700 patients to either avelumab until progression or best supportive care. The hazard ratio for survival was 0.69, and so that's the lowest hazard ratio for survival that we've seen in frontline metastatic disease. In fact, it's lower than any of the survival hazard ratios we've seen for immune checkpoint inhibitors in urothelial cancer. It worked across broad subgroups of patients, cisplatin eligible, ineligible, biomarker positive, negative. visceral metastasis, no visceral metastasis. The progression-free survival advantages were very similar to the overall survival advantages. And there was a really nice plateau in the PFS curves, showing about 30% of patients not progressing. And as you know, urothelial cancer is usually a lethal disease, and so it's really unusual for patients not to progress. We previously did a study with maintenance lapatinib 4 or 5, 10 years ago, dare I say it. And in that trial, we actually showed that 95% of patients effectively progressed. And I think that actually we saw that as well in the control arm. So I think that actually what this trial is showing is nivolumab is getting control in a significant proportion of patients and making those patients live longer. The study drug was well tolerated, in line with what one would expect. And the question you've asked, which I think is relevant, is that the majority of patients who progressed went on to get further therapy. 75% of patients who progressed went on to get further therapy, and over half of those received immune checkpoint inhibitors. And in percentage terms, that's actually much higher than we've seen historically. So just to summarize, I think that this is a practice-changing study in that it's achieved the lowest hazard ratios we've seen for immune checkpoint inhibitors in the frontline setting with urothelial cancer. In fact, it's the first survival advantage that we've seen. There were some durable responses. The drug was well tolerated, and many patients went on, in the control arm, went on to get subsequent therapy with immune checkpoint inhibitors, underlining how important it is to give the drugs early.
Excellent, Joe. So there's a question that I have right after the presentation. Is there any way we can better select patients for maintenance? Because we know, for example, with cisplatin first line, like 10 to 15% of patients that actually had the tail on the curve. They are exceptional responder. They have complete response. So it seems that from the first plot, everything is clear, all the subgroups benefits. But what do you think about the patients that actually got a complete response with a cisplatin chemotherapy on first line? Do they deserve maintenance?
Yeah, so our subset analysis, our differential groups were putting the stable disease and complete response patients together. And so we've not picked out the two populations. I think that one of the really big challenges that we face, and I think this is probably relevant, is that historically urothelial cancer patients have not done well. One doesn't have to go back too long. In fact, even some of the trials we're doing now show median survival of these patients is only 12 months from diagnosis of frontline metastatic disease, the median survival. And the median survival of the control arm in this trial was 14 months. And so I think when you put it to patients around this approach, and that the immune therapy does play a role in the disease process, and the subset analysis showed the PR/CR patients did as well as those with stable disease, I would be very nervous about selecting out the patients. As I said before, CR is not an exact science. RECIST 1.1 CR, can't occur in all patients. You pick target lesions at the beginning, you monitor those with time. My feeling is that as it currently stands, while I can see there may be 1 or 2 patients that have a good reason not to have immune therapy, contraindications, active ulcerative colitis, ongoing active infection, whatever it might be, I wouldn't be currently selecting out patients. What I would be doing is diving in, giving patients of therapy. And then a more complex question is there a time after a period of years when actually it's safe to stop therapy? And I think that's quite an important point, because we don't know that intervention early with immune checkpoint inhibitors won't cure a proportion of patients. We don't know if CR is cure, but we do know bladder cancer patients often have lethal and aggressive disease.
Yeah, that's a great point. And thinking in a point that is similar, you mentioned that maybe bringing immune checkpoints earlier was an advantage of the maintenance or the avelumab strategy in Javelin. So, and it seems that we tried to bring it very early with the Tezo or pembrolizumab in the combination studies, the Invigor 130 and the Keynote, but it seems that this strategy is struggling to show a significant clinical benefit. What do you think is the main difference between both strategies? Is there any downside of combining immune checkpoint with chemotherapy in urothelial cancer?
I think that's probably the most, in metastatic disease, with the data that's in front of us, it's one of the most intriguing questions. Two important points. Number one is we don't yet have the final data with Invigor 130. And number two is we have the press release from Keynote 361, but we don't yet have the data in front of us. So it's premature at this point to say we know exactly what's going on. But what we do know at the moment is in lung cancer, we saw clear additivity of chemotherapy plus immune therapy. In Invigor 130, when you give chemotherapy alone, you have a 44% response rate. And when you give chemotherapy plus atezolizumab, it goes up to 47%. 21% is the response rate of atezolizumab by itself. So additivity would be 40 plus 20, which would be 60%. And we're seeing the same 44 versus 47, a 3% increase. So from a response rate perspective, there doesn't seem to be a bounce. When you look at the Kaplan-Meier curves for progression-free survival and for overall survival for the combination trials, the first 6 months they stay together and then they go apart, which is generating the hazard ratios of 0.83 and 0.82 for OS and PFS, respectively. And of course, we don't know the results of the 361 pembrolizumab plus chemotherapy trial yet, but we know it was negative. And of course, it was a 1,000-patient trial, which is quite a robust study. So as it currently stands, there doesn't appear to be a big bounce in efficacy by giving them together. And remember that actually the chemotherapy plus immune therapy studies were not just chemotherapy plus immune therapy. You got maintenance immune therapy in the atezolizumab and pembrolizumab trials, combination trials as well. And so it's conceivable that the data, the curves going apart when the chemotherapy finishes, is that maintenance period of atezolizumab that's driving the benefit. And so I put it to you, as it currently stands, we know the maintenance approach is associated with a benefit. I think there are more similarities than differences between the drugs. So I don't think of atezolizumab in a randomized phase 3, if avelumab in a randomized phase 3 achieved a survival advantage, I don't see why atezolizumab with an identical design would be unable to do that. And I think many of the benefits that we're seeing with the chemotherapy immune combination is actually being driven by that maintenance period. So I would put it to you that as it currently stands, there isn't conclusive proof that chemotherapy plus immune therapy is associated with a benefit in metastatic urothelial cancer.
Yeah, these are great points. And at least now in Brazil, we had approved erdafitinib, a target agent for advanced urothelial cancer. So we're starting to enter a genomic area, precision oncology area in urothelial cancer. And some folks are ordering this test as the patient becomes metastatic, at the first line. So do you think this information being positive for FGFR mutation or fusion will change the paradigm of maintenance? Some guys say that this patient are not well responsive to checkpoint inhibitors. What is your opinion, Tom?
So my opinion on that is actually quite black and white as it currently stands. As it currently stands, we have a study with the FGF inhibitor erdafitinib in about 25% of patients who have FGF2 or FGF3 alterations. It's currently being measured by the PCR technique, although some people are using Foundation 1 to identify these. The response rate is somewhere between 30 and 40%, the progression-free survival somewhere in the region of 6 months in a single-arm trial. Those results are really encouraging. There are lots of questions about the biomarkers, and we don't have a randomized trial yet, and we have a study of about 100 patients. Now, if the response rate was 90% and the PFS was durable and was 2 years, I would say that's a testis cancer chemotherapy story. And I would say, yes, all patients should have that, although it's a subgroup of patients. Because the responses don't appear durable, and because we have the Javelin trial, which is a positive randomized phase 3 with a hazard ratio that reduces the risk of death by 31%, I would put it to you, as it currently stands, we don't know enough about erdafitinib to slot it into that space. And what I would be doing is I would be doing the following. I would be giving patients chemotherapy. I'd be looking for FGF alterations. I would give maintenance immune therapy. And then at relapse, I would have a discussion about enfortumab vedotin, or if FGF alterations, potentially erdafitinib. So I currently see the real seismic change being second-line therapy. Previously was immune therapy, erdafitinib, chemotherapy, or EV, but until 2 years ago, second-line therapy was immune therapy or chemotherapy. I now think that's completely changed. Frontline platinum-based chemotherapy, maintenance of avelumab, move those on, big benefit to patients, and then at relapse, EV or erdafitinib. A big change in urothelial cancer.
Yeah, it's exceptional, your view. I think I agree 100%. This study changed the paradigm. We're thinking more in giving this patient with stable or response maintenance now. So, and now thinking about a little bit more to finish about the future, what do you think will be the next step in metastatic urothelial cancer that will change this paradigm of maintenance? I mean, what would be the great change in first line? Maybe the combination trials, or even pembrolizumab plus enfortumab. What is going to change the paradigm that we just established in ASCO 2020?
There's one study that remains out there that I'm excited about, that will report out in the not too distant future. And then there's going to be a pause. IMvigor 130 may hit survival, but if the results continue in the mid 0.8s, there will always be this question about whether or not it was actually the maintenance period that was driving the benefit. Because 361 pembrolizumab plus chemotherapy is negative, we need to look at that data, but it suggests we're not going to be pursuing that approach. We also know that the Danube trial and the 361 trial were negative, and we know that that was a biomarker positive monotherapy. Now, if we're not getting over the line with monotherapy in the biomarker positive cohorts in the randomized phase 3 trials, there will be a question about whether or not we should be giving monotherapy based on single-arm trials. I suspect we won't. I know the atezolizumab data was promising with a hazard ratio of 0.68, but the numbers were small and weren't yet significant. So what I would put it to you as it currently stands is that we are going to be in a position where I suspect the majority of patients from a global perspective will get chemotherapy, followed by maintenance of avelumab. We know that the Danube trial tested durva-tremi in a biomarker agnostic approach and was not significant. The trial I'm actually quite excited about is the ipilimumab-nivolumab randomized trial in the biomarker positive patients, because the phase 2 data showed response in platinum refractory disease, showed response rates of 58%, which actually are high. And so I am hopeful that Ipi-Nivo may outperform chemotherapy. It's clearly not a home run. It's not because durva-tremi was negative. It would be unwise to be reliant on that being positive. But I'm hopeful of that. When that trial reads out, there's then going to be, I think, a 2 or 3 year pause, perhaps longer. Enfortumab vedotin plus pembrolizumab has a response rate of 74%, with 93% of patients getting some reduction in target lesions. Clearly, that combination looks very active. If those results are reproduced in a randomized phase 3 trial, it's likely that they will outperform the control arm, whatever that might be. And so I see a two-step process. I see this last trial come out. I'm hopeful it might be positive, but the history of bladder cancer trials, with the exception of Javelin in the frontline space, is they've been largely unimpressive. So sensible people say that would be negative as well. Once we have the results of that trial, which I hope are positive, we then will need to wait a significant period of time before subsequent trials read out.
Great. It's always grateful to hear your thoughts, Tom. They are exceptional. So I think we had an excellent discussion. Thank you for that. And I would like to congratulate you again for this exceptional role in leading the urothelial cancer field. So I'd like to hear if you have any final consideration for our colleagues here in Brazil.
Well, firstly, I can't wait to come to Brazil. First thing to say, as soon as this finishes, I'm going to jump on a plane, and I'd like to come and talk face-to-face around some of these issues in urothelial cancer. I'd like to talk more about the non-muscle invasive and muscle invasive space, of course. And I'd also like to, if I can, help with some of the trials that are ongoing to try and facilitate Brazilian participation and leadership in those trials. I know that Brazil is a country with fantastic research infrastructure and great and large patient populations. And so I'd like these global trials to be successful in your fantastic country.
Perfect. And we really need your support, Tom. We do have good centers here, but I think there will be plenty of opportunities to work together. And of course, to have you here in Brazil, it's always a pleasure, and it's always a great moment for us here. So thank you again. And with that, I would like to, again, thank you for the people that are watching this video, and we hope to talk to you again in the future.
Thank you, Dennis, for inviting me, and see you very soon, I hope. Bye-bye.
Bye-bye. Take care.